Okie dokie, folks. So I want to talk to you now about creating a safe environment for the because as with many of our advanced interventions that we utilise in emergency care, planning ahead and preparing for adverse events is absolutely key to delivering a safe sedation. And if we wade into this with no consideration for the situation we're in or the adverse events we might face, then we can definitely get ourselves into a world of trouble very quickly. So overall then, sedation should be a well-considered affair, definitely not something that we rush into. But why all the fuss? Why can't we just crack on? Well, there's two key issues at play here. So the patient can experience side effects directly related to the sedating agents that we've given, as well as some iatrogenic adverse events related to the sedation. Now, Simon's already described sedation as an entity that exists on a continuum from minimal through to moderate and down to deep sedation. And as we pass along that continuum, we get increasing depression of the patient's physiology. And that increases the likelihood of adverse events occurring, which, if we don't identify and manage promptly and effectively, might end up leading us to poor patient outcomes. Well, you might be sitting there thinking, well, I'm only planning on providing a moderate sedation, so what's the stress? Well, we know that the individual response to sedating agents can be really variable, so it's often not possible to predict with absolute certainty the degree of sedation that you're going to achieve. And because of that, many of the sedation guidelines quote or paraphrase the American Association of Anesthesiologists, who say that practitioners who are intending to produce a given level of sedation should be able to rescue patients whose level of sedation becomes deeper than initially intended. But to enable us to achieve this rescue of anyone who either becomes over-sedated or suffers the side effects of the agents we're using to induce the sedation, then we need to have appropriate monitoring established to allow us to rapidly identify those issues. And we need the equipment ready to manage any of the complications that might come our way. So firstly, let's consider what monitoring we want to have in place on the patient before we undertake the sedation. And a really useful guide on this is the RChem Safe Sedation in the Emergency Department document. They break down the degree of monitoring required by the depth of sedation being planned. And that's because, as we've said before, the further down that continuum of sedation we go, the more likely the patient may be to suffer an adverse event. So for minimal sedation, probably achieved just via the administration of Entonox, the minimum recommended standard is simply a pulse oximeter. Nice and easy. But that's because the chances of some serious mishaps occurring here are really pretty small, and the medicines involved are very safe with very few side effects that might require intervention. And so sedation beyond the minimal stage is very difficult, if not impossible, to achieve. So the patient's airway reflexes will be maintained, their physiology won't become significantly depressed. Now, that's not to say that you might not choose to monitor the patient more thoroughly, but the expected minimum is the pulse oximeter for minimal sedation. But as soon as we step up to injectable medicines, we also need to step up our monitoring, because the agents we're using often result in more cardiorespiratory effects, and the potential for airway compromise starts to raise its head. Now, there are also very blurred boundaries between deep sedation and anesthesia, and as we've discussed, there's a very real potential for over-sedation to occur due to the individual responses to those sedating agents. So RChem very sensibly suggests that the minimum standards for monitoring follow those set out by the Royal College of Anaesthetists in their document, Recommendations for the Standards of Monitoring During Anaesthesia and Recovery. Now, as such, the patient for a moderate or deep sedation should be hooked up to an ECG, blood pressure and SpO2. Now, the blood pressure cuff should be set to cycle automatically, and interestingly, there's actually no set guidance in the literature as to how often that cycle should happen, but somewhere around 3 minutes is probably reasonable. Now, you might be wondering about waveform capnography. Well, RChem mandates its use for deep and dissociative sedation, but only recommends it for moderate sedation. Now, in my opinion, I don't quite understand why you wouldn't put it on for all sedations. It's an extra source of information that's non-invasive, and it can give us some pretty vital information on the patient's response to the sedation. And don't forget, the CO2 is being measured, in this case, nasally, and so we're not really looking at the hard figures, but more of the trend that it provides during the course of the sedation. But actually, more importantly, we're going to use it to monitor the respiratory rate, as it's going to give us breath-by-breath feedback on this. And if we relied simply on our oxygen saturations to monitor respiratory adequacy, then we all know that we'll see a significant lag in the numbers after the patient becomes apneic. And whilst we're establishing all this monitoring, we want to think about activating and setting relevant audiovisual alarms with appropriate tolerances. Oh, and make sure the monitor is in a position where the sedationist can see the screen, or all that hard work will definitely have gone to waste. So we've set up the patient on their monitoring so we can observe their physiology over the course of the sedation, watching for signs that our sedation is at the correct depth and that no adverse events are occurring. But we also need to be able to respond to any adverse events that we might encounter. So what might we expect to see? Well, Simon already discussed the great paper by Bololio et al. In Academic Emergency Medicine, and they looked at the adverse events during procedural sedation in emergency departments. And as a review, they found that the most common adverse events were hypoxia, vomiting, hypotension, and apnea. So I guess it'll be no surprise to hear that we need to have access to oxygen, and the patient should be placed onto a reservoir mask prior to the start of the procedure and then maintained on it until they're fully recovered. We also need a bag valve mask and a full airway kit, including difficult airway set. Because if we encounter hypoventilation or apneas, many of them will be transient and will respond to just face mask ventilation alone, but we need to be prepared if we have to escalate up the airway ladder. So lay out an airway station, either on a trolley in ED or in an improvised kit dump in the pre-hospital setting, or at least have the equipment immediately to hand if it becomes required. Sometimes we have to take a pragmatic approach, don't we? And if it's blowing a gale and hammering down with rain when we're in the pre-hospital environment, we don't want to lose or damage our entire airway kit. So keeping it nearby and having someone familiar with its contents right by it to hand equipment across to us is probably a reasonable approach in those sort of circumstances. We also need to have suction checked and ready to go. It's unlikely that a flexible catheter is going to cut the mustard if we're going to encounter vomiting during the sedation, because we need to rapidly remove any vomitus that comes up to prevent contamination of the airway. So setting up a yanker is probably the way forward. And whilst you're at it, stick that yanker underneath the pillow or secure it somehow beside the patient's head and on their right-hand side. That means it's quick and easy to access if required, and it's on the correct side if you need to use it in conjunction with a laryngoscope. We also need a trolley that can be tilted head down, or thinking pre-hospitally, one in which we can raise the patient's legs on. Now again, in the pre-hospital environment, we might have to accept deviation from this ideal. If we're sedating a patient with a fractured and displaced long bone in order to extricate them from a vehicle, then this simply won't be possible. But we still need to consider what we will do in response to hypotension. So ideally for all patients, whether they're in hospital or out of hospital, we want to have 2 points of IV access secured and IV fluid available to manage any hypotension should it occur. And depending on the agents you've used, you might want to consider having the reversal agents ready and available in case of adverse events. But what about really bad outcomes? Well, reassuringly, out of nearly 14,000 sedations reviewed in their paper, Bololio found that there were no cases of cardiac arrest. However, following the idea of planning for the worst, we should definitely have access to resuscitation equipment for all of our moderate, deep, and dissociative sedations. So we've thought about the monitoring we need and the equipment we might want to set up. So whereabouts are we going to do this sedation? So I guess in the emergency department, due to the equipment and the stipulated monitoring requirements, ARCHEM state that any sedation which aims to achieve a depth of moderate or beyond, including dissociative sedations, should be undertaken in an area with resuscitation room facilities. Now, clearly in the pre-hospital environment, this is going to be less formal, and indeed, I think a degree of pragmatism is often required. As we've said before, the patient might not even be able to be moved from the location they're found in until the procedure's been undertaken. But in either setting, wherever possible, we need to ensure that there's 360-degree access to the patient to allow immediate access in case of deterioration. So we've covered quite a lot there, and you might be wondering how on earth to remember all of that. Well, our old friends the checklists are definitely going to raise their heads here, because they can be an absolutely indispensable tool to help methodically ready our patients, our colleagues, our environment, and ourselves for the sedation. And we use them in anaesthesia, surgery, invasive procedures, and heaps of other areas of healthcare. So why not in sedation? We certainly use them in our pre-hospital critical care team. And certainly their use is increasing massively. And if you haven't already got one where you work, then RChem have got a template available to download from their website. So sometimes in a busy department or a fast-paced pre-hospital scene, it's kind of nice to get everything set up and then run through a checklist to make sure everything's there. And in this case, some people like to remember things through the use of an acronym. And when it comes to sedation, you may have already come across the word SOAP-ME. And with a slight tweak, it fits exactly to what we've just discussed. So suction, oxygen, airway equipment, pre-oxygenation, medications, monitoring, that's my double M, and environment. So SOAP-ME might be something that you want to just bear in mind to get yourself prepped for a sedation. But in summary, don't rush into these sedations. Ensure that you've prepared the environment appropriately, you've attached all the monitoring required, you've turned the alarms on, you've set them to the right level, you've got all the equipment you might require for a deterioration in the patient's condition, and then you're good to go.
All right then, so SOAP-ME, you heard it here first. Love it. Okay, that's absolutely awesome. So James, I mean, you've nicely described the minimum monitoring standards that are set out in the guidelines, but you also talked about the need for pragmatism in pre-hospital care. So I'm going to pin you down on that point. And are there any situations that you've come across in which these standards simply aren't feasible to follow? I mean, come on, mate, there must be some, aren't there?
Oh, is this being recorded? I don't know if I feel like I'm
admissible in a court of law near you.
Oh, God. No, definitely not then, Rob. I fully monitor every single patient. No, yeah, I mean, you're absolutely right. There are definitely some situations we come across in pre-hospital care when we just simply can't follow these monitoring guidelines. As one example, so picture the scene, you know, it's late at night, you're at the side of a rural A road with a car that's rolled, you know, into a ditch, and the person inside is trapped and has also got multiple long bone fractures. You need to get them out of there before you can start definitively caring for them. But actually getting them out of the car is part of the procedure. And so that's going to require a sedation unless you want to drag them out screaming. So, you know, in that situation, it's not going to be possible to fully monitor them all the way throughout the sedation. You know, you're going to end up with wires getting tangled up everywhere. We're going to end up snagging on things, pulling lines out and so on. And getting patients out of cars is complicated enough as it is, let alone trying to do it whilst they're fully monitored. So what do we do with that? Well, I think we do need to try and put some monitoring on these patients, because ultimately we've given them these fairly punchy medications that have, you know, knocked off their neurological and potentially their cardiovascular status. So I think there's not really any guidance on this, but I think the minimum we should be aiming for is saturations and an end tidal. And again, I accept that even that might be pragmatic at times. But I think optimally, if we can monitor their ventilation and their oxygenation throughout the period of extrication, then that's probably reasonable. Because we need to think about what we're going to do with the information. You know, if we had them fully monitored up and we had a blood pressure cuff on and we had ECG on, and, you know, we saw their blood pressure dropped slightly halfway through the extrication, what's that going to change? What are we going to do? You know, whereas actually if the patient becomes completely apneic during an extrication, then you might say to the fire brigade, right, this is now an emergency extrication. They need out immediately. So I think you're right, Rob. There's definitely situations we come across. Another one would be the ABDs, the acute behavioural disturbances, when we're faced with a very agitated patient and you're never going to get any monitoring on those patients. And in that situation, I think you just need to get the monitoring applied as soon as possible once you've started the sedation. So it definitely can be challenging. And I think, you know, these are guidelines and these are standards that need to be adhered to as much as possible. But if we can't, then, you know, I think there needs to be a degree of understanding about the situations we're in and the situations we're facing. And importantly, we need to just document our rationale in the paperwork.
Yeah, I totally agree with that, and I think that's a really nicely answered question there, James. Because I mean, the guidelines are exactly that, aren't they? They are guidelines, they are best practice, and what we need to do is, if we do need to deviate from them, we just need to be thinking about the reasons why, trying to minimise the impact that might have. But of course, those occasions are definitely going to occur, aren't they?
Yeah, absolutely. And so, I mean, this is obviously thinking about the pre-hospital situation, but I mean, what about in hospital, Rob? Because I mean, your departments are very busy all the time. We know that. And, the guidance says that you're supposed to be monitoring these patients in a resuscitation room level space. But, I mean, I don't know. What about if that's not possible? Have you got any other options?
Well, yeah, I mean, like you were saying, I mean, I think that the occasions when you're going to have to deviate from the guidelines are less in the emergency department than they potentially are in the pre-hospital. But I certainly get with the acute behavioural disturbance patient, that is, across the board a problem, isn't it? But with regard to those sort of procedures that you're going to be performing, well, if you haven't got the resus room physically available, excuse the pun, if you haven't got that immediately available, then you can bring that monitoring and that level of patient care to another cubicle, I think is the easiest thing to do. So most of us will have portable monitors that have end-tidal CO2 for when we do transfers. Well, if you can move that into an area that is monitored and get appropriate staffing around you, then that's essentially going to be bringing the facilities to the patient rather than taking the patient into the facility. And I think that's often one of the things that's easiest to do. But I mean, you do just need to be cognizant of the fact that actually it's not just about the physical environment, it's about the staffing impact and the staffing levels. And your nurse is going to be tied up for a long period of time, and if they're allocated another 3 or 4 patients on top of that one, well, those 3 or 4 patients are not going to be getting any care because they're going to be monitoring this patient who's just had a sedation done. So essentially what you just need to consider is the wider impact of it. And I mean, the other thing is as well, it comes down to how emergent that procedural sedation is, doesn't it? I think that if you have something that can wait a little bit of time, then that's great. You can wait a little bit of time. Or if it's something that, as we talked about before in terms of our patient selection, if that patient might actually be one of those that it's a borderline decision about whether you take them to theatre or not, then actually just sending them to theatre and having it done there, if it's an orthopaedic procedure or whatever it might be, is something reasonable. So there are ways round it, but it will depend very much on local knowledge and local sort of policies and guidance, really, as to which direction you take. But it's pretty infrequent, to be honest with you, buddy, that you can't at least sort of create some form of space where you can get stuff done if need be.
Okay, nice. Yeah, and I like that idea of bringing the equipment to the patient and actually replicating the resus facilities just in a different space. So yeah, that's really cool. Useful for when your facilities are pushed to their limits, I guess.
Yeah, it certainly is. And actually, just before we wrap this section up, James, you dodged this quite nicely in your presentation. But talking about locations, so whereabouts are you doing these sedations, buddy, in terms of location when you're pre-hospital?
Well, I mean, that's the fun, isn't it? It could be absolutely anywhere. I mean, realistically, we've got 2 choices. We can either sedate the patient where you find them, or move them and then sedate. And it depends on why you're sedating them, exactly the same as some of the other considerations we've discussed throughout this conference so far. So is this an orthopedic problem? Is this a cardiovascular problem? Are we sedating to cardiovert and so on? But actually, often, I said there were 2 options, but often there's actually no choice. If the patient has got significantly deformed limbs or multiple fractures in a car, like we were just discussing, then actually the procedure we're sedating for is a combination of the extrication and the fracture realignment once we're inside. But if we're sedating for a cardioversion, for example, then actually we might be able to move the patient into an environment that's a bit more favourable for us and for them.
Fair enough, Jimbo, but I think, you're a pragmatic guy, so give us a few tips, really, on the sort of things you can do to control that environment, because, I mean, you've done this for a long time, What sort of things are there that are within your control, that are within your control to make this a bit safer? Because I completely appreciate, it can be anywhere, but don't tell me you wouldn't put some thought into what you're going to do to make it that little bit safer, buddy.
Well, that's very kind, Rob. And I do try and think these things through. I mean, it's taking the guidelines that we've already discussed. So the equipment that you might need and the monitoring that you are going to require. And it's trying to implement them in as much of an efficient capacity as you can. And I like the wording that you use, Rob, and it's controlling your environment. Because actually that's what we do as pre-hospital providers. Every time we go out is controlling our environment. And so I think what you need to keep at the back of your mind is don't make this procedure any more difficult or risky than it already is. So I guess things like making sure the area is well lit. You know, if you're in someone's house, then turn the lights on. Or if you're outside at the side of the road, then get some scene lighting from either the fire service or Heart. You want to think about protecting yourself, your patient and your equipment from the elements. Now, you might have to improvise here, but things like tarpaulins being held up by the fire brigade or something similar. Now, that might be to block rain or it might be to block sun, depends on whether your glass half empty or half full. But we need to think about the fact we're outside. We already mentioned this before, but we need 360 access if possible. But at an absolute minimum, we need adequate access to the airway. And I think if you can't get adequate access to the airway, then you really need to be asking yourself, should I be proceeding with this sedation? Now, ideally, we would move the patient first and we'd pop them onto the stretcher and then we'd wheel them into a clean, clear, well-lit space. The height can be adjusted for optimal airway management and so on. So I think if we can move them, then that's absolutely fantastic. And that should be the sort of optimal care package that we're aiming for. But like we said, often your hand is forced and you just need to look at your surroundings and you need to think about mitigating some of those problems that are going to be distracting and make this procedure more challenging and potentially more risky.
Awesome. Like them tips, buddy.